Hey, Chelsea. Can you hear me? Can you hear me fine? All right. Hey, guys. It'll be a couple minutes before we get started. Just waiting for the Zoom people to enter. Any questions for me? For anybody? Banter. You can ask anything you like. So sorry, Rob and Brandon couldn't be here for today, so we'll ask them lots of questions next time, but they're a bit busy and tied up, so it's just going to be me for today. The theme was funny shirts, so I got a shirt with, like, I don't know, rocket ships, a moon lander, satellites and stuff like that. So I got all those on me, and then I also got matching socks that have like planets and stuff like that and an astronaut on it. So trying to stay pretty coordinated here. We'll have to give you guys lots of funny clothing this week. So we have a theme for each day. So make sure you guys look out for that. I'm just going to check the messages while I do this. I got a dig in the shirt, sunshine. Thank you, Chelsea, for that. We'll give it a few more minutes. Any questions for me about anything? Feel free to ask. We have a few minutes, so feel free to ask any question you like. Could be anything. All right. Still got some people joining. Good. Well, we've got a question that says, any idea when we'll be up and running? So far, we're waiting for the 30th, and then we'll see from there. So we've been advised to have our clinic like this kind of shut down unless it's emergency only until the 30th of March. So we do telehealth. So we do video rehab. So we can do that. We can still see patients like that. We use Zoom as a platform. So there is one option at least. 1 second. So yeah, hopefully that answers that question. Any questions from anybody last time that was watching the video? No questions. All right, that's good. I like it. How's everyone doing out there? How's the social distancing? I guess you can't really call it isolation, but social distancing. Anybody having a hard time with that? Being a physio, it's very difficult. I'm used to being with people in close proximity all day, so it's kind of drives me crazy. And I was talking about it with Brandon and Rob yesterday after our video, and kind of got really pumped up after doing the video and the live feed. So yeah, it was awesome to do that, and it kind of made me feel like a physio again. There we go. All right, so a couple more minutes. Okay. So I'm just gonna check if there's any catching up on cleaning. All right, that's what one person's doing. Robert says, I miss you. I miss you too, Rob. I wish you were here. This is so much harder doing on my own. Yeah, so this is gonna be me doing the hip. So luckily I know a few things about the hip. I'm sure that most of you have had hip injuries in the past or issues or anything like that. So we're gonna be discussing a few things with the hip, more specific to the anterior part, so the front part of the hip. We don't want to go too crazy. I'm just gonna adjust this. We don't wanna go too crazy into detail. Oh yeah, we got a hips don't lie, so that's true. they don't lie because they cause a lot of issues. They can cause a lot of issues. So this is one topic that kind of hits near and dear to me, just because I've had a lot of hip issues myself. So I still have a tight hip flexor, you could say, that acts up once in a while, but it's when I got a Shakira. I ain't gonna be dancing today, so sorry to T Dot. I'm not gonna be moving my hips in the ways that you might like or not like. Yeah, so I've had a lot of issues in my hip area, so we can go through some of those things. I love sharing stories about injury just because people think, I don't know, physios are invincible, so we're not. We just try to take care of each other. So a lot of physios, even me, when I first started my career, I didn't do a lot of the things I preach. So for the first 2 years, I kind of worked like 60, 65 hours a week, treated quite a few people, and I didn't really do the things that I recommended. So I don't know if patients were buying into that or they could kind of feel the vibe there. I was going to give a few more waves. But I realized after those 2 years, I started becoming more active, started taking care of myself a little bit better, cleaned up my diet a bit. Not that it was too bad before. T-Dot might know how much we used to eat. So yeah. And yes, can hips be issues for low back pain? Yes, it can be. And we're going to actually get into that in a bit. So I promise I'll answer that question. Yeah, so hips can cause back pain. So for me, again, I became more active and started doing, kind of practicing what I was preaching. And then I realized, hey, like if I just take care of myself, be proactive, I won't have any issues. So a lot of this can be done proactively because it is a common issue. I see it a lot with myself. I see it a lot with some of the Olympic lifters that I treat, and in various different sports, so runners. So it's kind of the whole population. So even if you're in an office setting, you can have those issues too. So this can affect anyone. So without further ado, we're going to get into the hip. Sorry, I have some notes here. We're going to go through a little bit of anatomy. Hopefully it's not going to be too boring, but it kind of goes through some simple things with the hip. We don't want to overcomplicate things, and even like the glute stuff like that, we're going to do maybe next week or later in the week and kind of talk about that. So we want to touch base on the anterior region of the hip. So we're going to look at more so the hip flexor, so the iliopsoas. We're going to look at the joint itself. We're going to look at the adductor, so the groin area, and kind of go from there. We're going to go through some common injuries, a few common injuries, two of which that I've had. So I'm just going to adjust this a little bit. There we go. So I've had a couple of the injuries that we're going to talk about, and yeah, we'll kind of take it from there. And then maybe today we'll leave more time for questions. And if you want things to clarify, you can always ask whenever. So I'm going to pull up some anatomy. First of all, I'm just going to I'm on Zoom as well at the same time recording. So I can just flip the screen here so that way everyone on Zoom can see. So we're going to go share a screen to Microsoft Word. Where is it? Sorry, one second. So we're going to go to Microsoft Word here, where I copy pasted some images. I'm just going to take the phone off here, off the little tripod. So we have, actually, you know what? So we have the hip here. So right here, the image is the lower vertebrae. So here you can see the lumbar vertebrae, and then you see a couple muscles kind of branch off and go down the leg or the hip. So someone asked a question, can hips be the issues for low back pain? Yes, it can. Oh, beautiful clinic. Thank you very much. I can do a tour for whoever wants to later. So you can see that the hip flexor, which are these two muscles here, go all the way down into the lesser trochanter in the femur. Not too big of a deal for memorizing the bone name, but those muscles can lead to a lot of issues. They're very powerful muscles. They're involved in quite a few things we do for squatting, running, whatever it might be. And due to the fact that they originate, or one of them originates from the lumbar vertebrae, the transverse processes of those vertebrae, you can get some referral pain into the back from hip issues. So we'll discuss what referral pain is in a bit in the next page. I'd say slide, but it's Microsoft Word, so the next page. So you can see there's this muscle, the psoas major, and the iliacus, and these form the iliopsoas. So that's two muscle groups, and they insert into the femur here, into the lesser trochanter. So that makes the movement of your hip, which since the hip flexor, it means it helps you move your hip just like this. So that's flexion of the hip. But when you think about a squat, you're controlling the descent. So that's still flexion of the hip. That's still involved heavily with the hip flexor. So if we flip back over, we have, again, the same image. We also have the inguinal ligament, which can cause some issues. So typically with a hip flexor strain or tendonitis, it's in this white part here. So if you can see this white part, that's where you have a lot of the issues. The red meat here, the bulk of the muscle usually doesn't have anything that's wrong with it. That's the force production part of the muscle. The tendon is the part that connects the muscle to bone. That's typically where we get the issues. Not always meaning that's where the pain is, but that's usually where the active inflammation occurs. So that's the hip. Not too bad in terms of anatomy. Learning it, on the other hand, may have been a bit more difficult in school, but that's kind of how we could think of it. It comes down from the back segments and the ilium and goes down into the femur. So if we go down the page, here is referral patterns of the hip flexor. So referral patterns is where you could feel pain. So if you look at the far right here, you have the hip flexor areas here in the X's. And if you look at these other two images, there's your referral patterns of a hip flexor issue. So whether it's a strain or tendonitis, these are the common areas. So the concentrated part of it is where a majority of people feel pain, or there's a majority of the symptoms. And then the smaller dots on the outside are kind of the outliers. So you can see for the most part, you have pain in the front of the hip. This is the front shot of a body. So if you look at the one on the far left, that is the back side. So your lower back. So since it does originate from those areas, that means you can have pain in the low back. Wherever the muscle travels, that's where you can have pain, and outside those areas. So yeah, if you do have pain in those areas, could be likely due to a hip flexor issue. And the hip flexor is involved in the low back region. So that's why you can get some pain there. You can let me know if that does answer the question. And if not, I can kind of clarify it for you a little bit. Oh, we got someone else that joined. Hey, Jamie, you joined. It's been a long time since I've seen you, but yeah, so that's the hip flexor and the referral patterns there. Anyone want me to explain that anymore, or is that fine? Jamie's probably good. She's a physio, so she probably doesn't need further explanation on that region. Yeah, so that's a brief description of the hip flexor. Just to keep things simple, I like to do that. Here we have the adductor muscle group, so the groin. So people say they strain their groin. These are the big muscles. So you have quite a few muscles involved. The adductor brevis, adductor magnus, the adductor longus. So you have all these big muscles that control the stability of the hip. So these help you with single leg stances, when you're squatting, again, running. So these help keep you stable. So again, in periods of overactivity, overuse, or a very heavy demand on the body, you can develop some issues, right? So we discussed last time that you could have a tendonitis issue, which is more of an overuse issue, or you could have a strain, which can happen from one big event. Like if you're, I don't know, going from like lunging to the side very quickly in sport, you can have these issues. Or for me, when I squat too heavy, which to most people isn't actually too heavy, that can cause some issues too. So you have this big muscle group, and it's quite thick. In physio school, we did a lot of cadaver labs and got to dissect, so we could actually see and appreciate how big these muscles are. These things are huge. So it's nice to to see actually in your hand and kind of get a bit of appreciation for that. So if we go down, we have the referral patterns for an adductor strain, so a groin strain. So you have the different muscles and where you feel the pain. You have the adductor magnus, and that's kind of the inside of the leg. Quite a bit of pain from anywhere into the upper part of the hip into the middle of the knee, or the medial aspect of the knee, the inside of the knee. So then you have the other muscles where you get the pain symptoms. Yeah, so you got all those areas. So quite an uncomfortable area, as you can see, that it affects people quite a bit. So a lot of the people that I see for this injury can be pretty irritable, right? It's not a comfortable spot. It can lead to a lot of even embarrassment too for some people. Like they're, it's an awkward area for people to get treatment. I treat everything the same, so for me it's all good. I just have a lot of discussions with patients, and if they're comfortable and things like that. So if you see a physio, it's all good. We're all professional. Yeah, so you kind of go down here. There's your actual hip joint. So this is a very simple image, and I want it to be simple just because I don't want to overcomplicate things for everyone. So you have the acetabulum, which is the socket. You could think of it as that. The femoral head, which is the ball, and the femur, which is the thigh bone. So it's a ball and socket joint. Ball's right here, the socket's right here, and it articulates. So it's a wide range of motions it can perform, kind of like the shoulder, but the hip joint, aka the iliofemoral joint, is very stable. There's a very deep socket that supports the joint. Shoulder is the socket's not as deep, so it's not as stable. So you don't see too many joint issues with the hip. What you do see with the hip, and I've seen this over years and years as a physio, is this spot right here between that femoral head and the acetabulum. There's a little bit of a gap. So when that gap is reduced, that's when people say there is osteoarthritis or some joint degeneration. So if you have less space in that gap, that just means you have osteoarthritis. Actually, it doesn't really matter where it is. It's just a less space in between the joint. You have osteoarthritis. So can be quite uncomfortable. So I've seen tons and tons of individuals with so after hip replacement surgery and before. So you have quite a few patients individuals that can have hip replacement surgery if the joint has eroded too much. So it is an option for individuals. We try to avoid it where we can. So it is preventable in some contexts. So if you're pretty active and healthy for the duration of your life, you have less likelihood of developing this issue, and you can prolong the surgery too. So you don't have to get it when you're young. If you're healthy and strong and take care of yourself, you can avoid these issues or prolong these issues. So I had a professor that wrote wrote numerous papers on this. And when you look at joints, you have less impact in joints that are strong. So if the muscles are strong around the hip joint, you have less impact in the joint, less force. So then you have less degeneration. So over time, that can help quite a bit. It's hard to treat these cases sometimes just because you have so much pain in some individuals that they don't want to move, or some of the exercises we ask them to do hurt quite a bit. So like anything, you want to be safe. So we kind of discuss with patients, hey, this is what normal pain is like. We don't like saying pain is normal, but to a certain extent with injury, you're going to have a bit of pain. So we try to normalize things and be like, hey, this is what you should expect. And hey, if this happens, then let us know, and then we can adapt the exercise or modify it. So if we go back to this view here, we'll go down the page a bit. Yeah, so that's the last image I actually wanted to show. I thought there was one more, but there is pelvic tilt I wanted to talk about, but we can do that on me as a model. So yeah, let's just go back to me. So any questions thus far, guys? Hopefully you'll learn a thing or two about this. I think I have, oops.
I don't know what you...
Oops, sorry guys. So we have, do you have suggestions? Actually, hey, can you repeat the point about muscle strength and forces on joint again, please? So if we have stronger muscles around the hip joint, for example, you have less impact or less joint load in that area. And they also done some research that, again, with less weight, if you weigh a little bit less, you're not going to notice as much joint impact as well. That makes sense. Less load means less impact or less force in the joint. So that's what I was referring to. If you strengthen the muscles around the hip, you reduce that shock to the joint, like kind of like good shocks in a car, but much more expensive or worth a lot more. So hopefully that answers that. Also, another question is, do you have suggestions for alternative cortisone injection? That's a good question. A lot of patients ask us about cortisone injections. Kind of out of our scope because we're not physicians and we don't prescribe cortisone. So my alternative to cortisone is always activity, physical activity. So seeing a physio, getting an active program in which you're doing quite a bit of exercise to increase the strength of the muscles around the joint. So you want to be able to control those things so that way you can kind of control the condition a bit better. So what you could do is do a heavy strength program. Heavy doesn't mean heavy weights, it just means to get things done consistently, right? So trying to work out every day, trying to be active, that can reduce that load on the joint by strengthening those muscles. So that would be one alternative to cortisone. Other injections that are offered, again, out of my scope, so I don't want to comment too much on them. But a lot of it's going to be self-management. So getting educated on what exercises or movements to perform or what to avoid in daily life. If the osteoarthritis is pretty bad, there's certain things you don't want to do. You don't want to do like quick twisting on one leg, things like that. So that's kind of how I would answer that question. Does that answer both of those questions, guys? There's the one about the joint load and one about the cortisone injection. I think that means yes. There's no one responding. So, and again, we can get to questions after as well. I'm pretty open to that. If you're already very active, I'm a spin. Okay, so this person's very active, is an instructor, a spin instructor. So in that case, I would say to talk to your physician or your physio. I know that's hard, and it's hard to answer these questions in some context just because I don't want to ask how bad the osteoarthritis is, but it depends if you do an active strength program. So if you're doing mainly cardio, whether it's running or spin or biking, then you want to be able to do some sort of active strength program. So that could be a physio designing one for you and seeing how it goes. So are you pretty active? Like, do you do an active strength program? So that doesn't mean lifting heavy weights, but do you do any kind of strengthening other than spin? So HIIT as well, okay. Do you do any resistance training at all? So we got HIIT, yes, okay. So, I mean, I'd be curious to have a chat with you. So you could direct message me or email me at sunny@pursuitofmotion.com, and I can actually talk to you a little bit more detail about what kind of activity you might be doing. So I just want to see what resistance training you're doing, and maybe there's modifying it. Maybe certain ones are causing pain. Yeah, I just want to make sure I know what you're doing for activity. So hopefully that answers that. No problem. Yeah, I know it's difficult to answer because I get pretty interested in these things, so I want to be able to help as much as possible, but I also want to make sure I got all my bearings and know the exercise programs quite a bit. So yeah, so feel free to email me or direct message on Pursuit of Motion. and I can get to that. We do telehealth as well right now, so we do have this program in which we can treat individuals over this kind of system. So we use Zoom and do one-on-one treatment with you. So you can take us to the gym and do your workout there, and can actually pinpoint things a bit for you. So we can actually go through your exercises and figure out, what we can need to modify or anything like that. So yeah. So there's that. So the rest of the questions, I'm sure I'll get asked after talking about injury. So we have a few things to talk about. Again, not going to talk about everything in the hip, just because this could be a topic over like every day of the week for for us. So injuries, we have a hip flexor strain. I'm sure a lot of you may have had some symptoms of this or some issues of this, and we also have tendonitis. So I'm getting some questions actually. How are you doing? I'm doing pretty good. I'll answer. You can direct message me if you want to ask me how I'm doing in more detail. So yeah, we have hip flexor strain and tendonitis. So strain you could refer to as a movement that causes an injury. So let's say I don't know, squatted too heavy one day or too quickly, and then I started feeling hip pain. That could be considered a strain. Tendonitis could be done over time. So let's say, again, if you look at the same squatting example, squatting for months and months, maybe inappropriately, not doing the appropriate volume, and then boom, you have some tendonitis that starts, and it's a little bit more chronic in nature. Both can have similar kind of symptoms. You kind of get burning. I can stand up here. You get burning into the hip right here and down the leg a little bit. I have issues on my right hip, so right in there is where I got all my issues. So, and that's actually if you're sitting for a long time. So if you think about your leg, if you're sitting like this, your muscle is shorter, right? If you're standing, it's a little bit lengthened. So sitting, short. So if it's short, it gets tight. So if I sit for even like, I don't know, 30 minutes and stand up pretty quick, I can get quite a bit of pain for a few steps. So I kind of limp. I'll get up, right? And then I'll kind of limp a little bit just because there's quite a bit of pain. That's if I don't manage it. So that doesn't mean it's every day, all day. So if I do manage the injury by, stretching, rolling out, things like that, things that work for me, it's not too big of an issue. So yeah, I think that's the best way to explain a hip flexor strain or tendonitis. So that muscle group does get inflamed, whether it's from overactivity, doing something inappropriately for too long, whatever it may be. So you kind of get pain in those referral patterns that we talked to about, right? So in front of the leg, down the leg a little bit. Yeah, so it doesn't commonly go past the knee. It can. And the hip adductor strain, those two muscle groups work together. So I have issues in both. So it's pretty easy to show rehab programs when I have athletes or anybody actually from the public come in. I have a lot of things to give them, and effective things. Like there's not like there's like 40 things to do. There's a few things that you do your own way for your own injury, and then you have your own management technique or a management system. So as a physio, when I first started out, just because I talked about being a physio starting a while ago, I used to care a lot. I mean, actually, no, that sounds bad. I mean, I would give people these extensive programs and everything that you need to do for rehab. And I realized that was just too much for people to handle. So some people not being very active and me giving them, I don't know, 8 exercises would be too much. So it was all the right thing to do, but maybe not the right way to conduct it. So now I keep things pretty simple, whether you're, again, somebody who works in an office, someone who's working out just the weekends, or an elite level athlete. Relatively similar types of exercises in terms of management techniques. And I like to do warm-up programs or stretching programs for patients I work with. With strength and conditioning, that comes to going to the gym. So I give people these exercises to do, and I expect them to do it either at their fitness facility or at home, and kind of get things done that way. So the things that we can manage and control, we do a lot in the clinic. So I'll say, hey, here's your management techniques, which consist of rolling and icing, and then doing some stretching. So, or tweaking squat. So I had an athlete last week that had some issues with squatting, and fixed up the technique, did some stretching, and he was good to go. I saw him a couple times, and that's about it. He has to go to the gym, monitor his symptoms, and that way you're coming to physio less, and when you don't need to, and you're treating yourself. So the biggest thing is we want people to learn body awareness, right? So knowing, hey, this is an issue, I should probably stop, or hey, I can push through this, it's not too bad. So when I have my hip pain when I'm squatting, I know when it's an issue and when I should stop, and I know when I should be kind of continuing as is, right? So whether it's putting less weight on or just stopping altogether. And sometimes I just get maybe too ambitious or excited and just, I guess I make some mistakes sometimes. So physios, we bleed as well. So yeah, so with the hip flexor, sorry, I keep going off in tangents. Strains, tendonitis, that's common. Same with hip adductor, so that groin area, so kind of in this area, you get a lot of those issues too. So lunging quickly to the side, you can feel a bit of a tear sometimes even. People say, oh, I felt like I had a strong pull. Those can be pretty uncomfortable because those can radiate kind of high up into the groin, a sensitive area. It's not very comfortable because you can notice it in every step. I know a lot of people probably contest to that because they've had these issues. So you have those strains. You also have what's called iliopsoas bursitis. So the iliopsoas being the hip flexor. Deep to it, you have a bursa, which is a fluid-filled sac that helps reduce irritation and friction. So it kind of cushions the area. So if you have a lot of hip flexor usage and a lot of friction in there, you can get bursitis, which is an inflammation of that sac, of the bursa. So yeah, those can be pretty uncomfortable too. Those can take some time to manage as well. So all these things, a lot of people talk about, hey, I have hip issues for so long. A lot of them can be managed pretty easily. It's just you have to, write down what activities, or keep in mind what activities are bothering it, and then kind of go from there. So, saying, hey, I don't want to do this and this, and see what it does, right? So if squats are my activity that aggravate things, then maybe I'll take out squats and see if it helps. And if it does, then well, there's the activity, then it needs to be modified a bit. So I don't like getting rid of things permanently. I just like trying to tweak programs a bit, tweak movements, and then see how it goes. Yeah, I got a question here actually. If someone had adductor tendon pain with isolated movements only, resisted adduction, would your exercise starting point be isos? Or so if you're looking at that, you'd start, typically we're advised to start with isometric strength, so meaning activating that muscle without actually moving. So if you're looking at, the question was hip adduction, which is bringing the hip in. Let's say if I'm pinching this roller and just pushing in, that's an isometric movement. That means my joints are not moving, but yet they're still activating, so they're still strengthening. So that would be the way to start. Yes, it's always good to be too safe. That way you won't cause any injury. If you did an eccentric muscle contraction, so lengthening the hardest muscle contraction, then yes, that might be too aggressive to do. So isometric's fine. If you don't have much pain with that, then probably step it up a little bit and do resisted adduction. So you could either grab a band, kind of bring the leg inwards like that. So that's a pretty good question. So isometric's good to start with. I try stretching it out. So for me, I always tell people, hey, do you have full mobility or do you feel stiff? If you feel stiff or don't have full mobility, it's always good to regain that mobility through stretching. There's like the butterfly stretch. There's quite a few ways to stretch the adductor muscle group. So I'd say, do you have mobility? If you have full mobility, then yes, increase the strength, increase the activities a bit. So that's the bursitis as well. And we can go through a number of exercises too. So we can look at quite a few things that anyone can do. You don't have to be, again, a high level athlete or go to the gym all the time. You could have issues doing anything, even sitting for a long time. So I got a question here. Sorry, I look at the camera. I feel creepy like that. I was just curious if isos would be too easy if they weren't bothered walking and only with isolated movements. Yeah, I mean, as a physio, I would assess someone like that. And if you had no pain, With ISOs, and yeah, maybe we could step it up a bit. If the next day you notice no issues, then maybe do some concentric motions. It's good to be conservative in a way, because if you take it too easy for a day, the next day is going to be good, right? You're not going to have any issues. If you get too ambitious and do something too difficult, then you could pay for it for a few days. So I like to have people do things that they're capable of doing, and not having to take 3 days off exercise at the gym or their sport. So I think what you're doing is correct. You just might have to upgrade it. So if you don't have pain the day after activity, then maybe bump it up a little bit. If you feel like you didn't have a workout, just increase it a little bit. That's what I would do. So whether it's concentric or eccentric, yeah, that's a good one. So we got a question about bursitis, common symptoms. Typically with those, I find there is a bit of crossover with the hip flexor strains, because it's in the same area. So typically what I hear about patients is, since it's an active inflammatory response, I always tell people, or patients come in and say there's pain kind of in this area here with some radiation, but I find there's a lot of local pain there. So, and it kind of increases with activity. At the end of the day, they find quite a bit of pain at night. They're waking up pretty stiff. Those are common things that I hear about it, which can be common of a hip flexor strain or tendonitis. So a lot of it comes down to, for us to assess the area. So for exercises, I think what it says is initial exercise for bursitis. Again, with every injury is mobility affected. If mobility is affected, then I would work on that, whether that's stretching or dynamic motions or something like that. I would focus on those kind of things to do. So yeah, that's the best way to start off with that. So as an assessment, our biggest skills is what we do with you, right? So we assess range of motion. We're movement experts. So if range of motion is affected, we figure out why is it affected. If it's the injury, then it gives us a list of things to focus on for exercise programming or prescription. And if strength is affected, then yes, we know we have to strengthen at one point. A lot of the times, if you activate a muscle that's injured, it's not truly weak, it's just protecting itself. It doesn't want to get injured more. Your body doesn't want you to get injured more. So it's kind of like a protective response. So if there's true weakness, then yes, there's lots of things to work on. So everyone has their own unique, let's say, like a problem list of injuries. So we kind of focus on those things, or any physio would focus on those things. That's a good question. So for stretches and things like that, I can show you a few things that I do every day. What do we have? Oops, sorry. Oh, sorry. Yes, you can walk. I think that's the question, but yeah. So bursitis in general, that's going to be the case, whether it's in the shoulder or in the hip. Always got to have pain-free range of motion. So lots of the times you can have things affected in terms of motion, so you need to adjust the posture or movement or things like that. Actually, the one thing I wanted to talk about was pelvic tilt, which some of you may have heard about. I know there's some physios on here, or physio students, so I should get them to chat about it. So you have pelvic tilt, rotation. So what you have, and I was going to show an image of this, probably better if I demonstrate it. This is for T-dot. This is where my hips don't lie. So you have anterior pelvic tilt, which is kind of shifted forward like this, and posterior pelvic tilt kind of like that. And you do, technically you have a little bit of anterior, so coming this way tilt while standing. Or in general, you have a little bit more anterior tilt. Your pelvis isn't completely flat like that. So when we look at mechanics and things like that, so when you look at movement patterns, we want to make sure that things are neutral or things are in an optimal position. So if you have too much of that pelvic tilt, then it can cause issues. So if you have a really tight hip flexor, for example, we just talked about that, then you're going to have more anterior pelvic tilt, right? So you're going to have more tilt coming like that. And we don't always want that because that can strain the back a little bit more. So if I'm going to grab a stick here to do a squat. So I know I'm in jeans, but it will still work fine. So if I'm doing a squat, right, I like to use any kind of bar or stick just because I like good posture. So if I'm squatting, I'm coming down like this from the front, right? So coming down and up, down, up, right? So from the side, I have a squat as well. So if I have too much anterior pelvic tilt and squat, there's a lot of torque on my back. So if you have a lot of weight, that can put a lot of tension on your back. If I now tighten my glutes and get a little bit more posterior pelvic tilt and then squat, my back's a little bit straighter, right? So that's something I kind of train with anybody doing a squat is, let's see how the tilt of the hips are. So if there's too much anterior tilt, I tell them to tighten the glutes, bring it back into more of a neutral position, and then kind of go from there and see how their hips are moving throughout a squat. I know I didn't squat too deep, but I'm a bit stiff. And if people have more questions about that, I can answer that as well. So you don't want to squat deep as the pelvis kind of rotates more anteriorly because you can put more torque on the back. So then you can cause back issues. I had an athlete prior to this clinic closure and this crisis around the world that had back pain. And he kind of had it back into this side here. So I realized it could be more of an issue due to the hips. He was squatting pretty heavy, but when you looked at his anterior tilt, he had quite a bit. And you could see as it tilted, like as he got tired, it was tilting more and more and more. So we stretched out his hip flexors. And then we did some modification of his, like finding a neutral hip position. So once he adjusted those after a couple of weeks, like he was good to go. He was squatting close to what he was squatting before. So yeah, that's a good thing that I trained. So that's looking into movement patterns more so than anything. And then it's kind of cool, like we'll play around with it at the clinic. So, I mean, we have rigs here, for instance, that we could use. You have a squat rack, things like that. So we can actually use some equipment with our athletes or anyone who's active and kind of see what their mechanics are like during the motion. Oh, I got a what's up, buddy? Doing pretty good, Noah. Considering we can't see patients live right now. So another couple exercises to do. Again, I'll show them. They're pretty straightforward to do, so you don't need much equipment. So let's go down to here. I'm just gonna, yeah, there we go. So doing a hip flexor stretch. I have a mat here. So a pillow would do too. So you put one knee down. Actually, let me just move that down a little bit more. There we go. So, sorry, I'm just gonna move this back a bit. Oh, apologies, guys. There we go. So we have this mat here. You could just use a pillow at home. You put one leg down, right? So, and then one leg forward. So I'm stretching the right side, which is my problem side. So, and then bending forward until you feel a strong pull in the front of the hip. Like I get one already right in there. So once I come to a point where there's a bit of a burn, but I can tolerate it, I hold for 30 seconds, doing 3 times. Really good to do that before activity. So that athlete that I had that tilt, I had him do this stretch quite a bit right before he squatted, and he found some improvement. So the best thing to do is to do these stretches in between activity to see if they help. So if they help the motion and you feel less pain, then kind of continue stretching during the activity. So even for me, I'll be stretching and rolling during my workout. So I'll do some squats and roll out and do some more squats, and it kind of keeps me going. So you kind of got your own response-based feedback there. So you do something, it makes you feel better, keep doing it, right? You do something, it doesn't make you feel good, adjust it a little bit. Yeah, so if you don't get a stretch that way, so if you're pretty flexible, I have a stool behind me, so you get the foot propped up on something, and then you come forward, you can also increase the stretch a little bit more and just lunge a little bit more into it. Again, I get a stretch no matter what I do. So doing this 30 seconds for 3 repetitions, right? So doing that on each leg 3 times, 30-second holds. I'd say do that every day before a workout. That should be a warm-up. So we often talk about stretching certain areas. Yeah, so we often talk about stretching regularly, and everyone's always like, well, how much do I stretch? How often? I'd say it depends on what is the issue, right? So if you have a hip flexor issue and a shoulder issue, then you have your own program for that. So it doesn't mean you have to stretch every single joint in the body, because that would take longer than a workout would. It just depends, right? So if you know you have a hip that's a bit tight and a back that's a bit tight, then you do your own warm-up program for that. So before your warm-up for the sport or for the activity, you do your own physio, I guess you could call it, or your warm-up program, and kind of get into activity. So at the gym that I train at, there's a general warm-up, and I'll add my own stuff to it. I have a hip that's, again, not so good. You heard that a few times. And then I'll warm up with the group after, or, you know, get there a little bit early. I'll do the bike warm up. Another one you could do, there's a bench right behind me, is called the Thomas stretch. So you could do it on the bench. Again, if you're not too tight, then you might not feel it. You'll see it with me. So what I'm doing is I'm stretching my left in this case, because I'm facing you guys. What I do is sit right at the edge of the stool, or even a bed at home is perfect. And I lift one leg up, so my right leg's up, and I just fall back gently with control. And you can see there's a little bit of a gap here. My leg doesn't go all the way down, indicating that I likely have a bit of stiffness in my hip flexor. If it wasn't too bad, I'd be a little bit lower like that. If you don't feel anything, you could get on a higher surface, or kind of let the leg fall off the side a little bit. This is a good stretch. You can get a partner. If I had Rob or Brandon here, one of them could push down on this leg and get more of a stretch that way, right? So this is easy, letting gravity do its thing. If you do the other side, you just switch legs. Mine, again, is a bit sore, so I do feel a stretch right away. You could do things like for the adductors, you could kind of go against a wall and kind of come around like this, and then bring the legs down. That can stretch quite a bit into the groin. I do this again every day. Even if I'm sitting at home reading, I just grab a book and sit on my wall and just let my legs go, let gravity do some work. And then, you know, 20 minutes later, I could barely stand up. Just kidding. Bad joke. But what I do is I sit for a couple of minutes like this and just read, put my elbows on my legs, and just push them down. And then I get quite a good groin stretch. Another one you could do is a butterfly stretch, right? So you could do, you've seen goalies do it. Luckily, these jeans are very, very mobile. Coming like this, legs out, and getting a good stretch in the groin. And I can lean different ways. So I tell people, you guess you could do exercise the way I show, or kind of change it up, right? Lean left or right, really localize that stretch, and target that area. And that area is the area that causes pain or causes you any issues. So that would be a few things you could do as per warm up. Even grabbing like a roller or a cool little ball. The ball wise, again, and athletes at the gym I go to can contest to this, I'm always rolling around, right? So if have some hip flexor issues or down my quad or groin, I'll actually push the ball into the area that's sore, let it release. So this exercise, another one to do, is pushing into an area that's a bit sore, staying local in that area, keeping the pressure consistent. And once it kind of lets up, you go to the next spot, right? Push in, lets up, next spot, and kind of go through the whole hip and groin that way. You can stand up if you wanted to and push it in, push it up against the wall, whatever you like. Pretty straightforward. You could use a foam roller, and again, size, it could be a longer one, no big deal. You put it on the ground. I'll move this back a little bit. I realize I haven't been doing this with my Zoom people, so sorry. Yeah, so you got your roller here, and you can kind of push it right into that hip flexor, right? So again, pushing into a spot that's sore, holding for the pain to go away, and then the next spot, hold for the pain to go away, next spot, just like that. You can get into your groin as well, or your adductor muscle group by coming in sideways and rolling in that way. So again, might be a little bit awkward, but it gets the job done. I kind of, again, push a little bit of weight. I kind of contort any way I can to find that point. So whatever it takes to get that spot, I push in quite a bit. So one of my favorite things to do, let me just adjust the height here. Yeah, so that's a few things to work on. Let me just see if there's any questions. Yeah, no questions yet. So that's the thing is pick your area that's sore or causing you any issues and working on it consistently, right? Hammer it down. Do it every day. See how it goes. If it gets better, then you know, well, that's the area, and kind of go from there. So even icing is a really good idea. I like ice quite a bit after a workout, especially to manage some of the inflammation. I know there's some arguments about the usage of ice, but I feel good when I put it on, so I continue to do it. So yeah, that's kind of some of the stuff I had for exercise. Trying to stay away from too much equipment. I know most people have foam rollers or something they can dig in, like even a rolling pin would work just fine. And those pretty much, most people have those. Yeah, anybody have any questions? Either on Zoom or on Instagram Live? Hopefully that covers a few things. No questions? Any questions at all? Let me just wave. Oops. There we go. Great segment on anterior hip. I knew it was great. I'm biased though, because I did it. So, well, I mean, the U of A did it. They helped me learn all this stuff. So can you explain a little more about how anterior? So, okay, so the anterior pelvic tilt. So, and again, I'll demo this and maybe I can get an image of it. So, and then you can have issues with either tilt. So if you have too much anterior pelvic tilt, you have too much curvature in your low back. So not ideal for joint loading, right? So if you have a normal curve that's designed to take as much impact or as much force, if you deviate from that curve, so bad posture, for instance, that puts more load in your joints. So you could think of it as if you have too much tilt, you have too much lumbar lordosis, and as you go down, it just puts more and more torque through your back, right? So you're not getting ideal loading through your joints because they're not stacked up. They're just kind of, you know, they're too spread apart. So as you squat, as you go down, you just get more and more curvature. You get anterior pelvic tilt anyways, but if you get too much, then you're going to have quite a bit of issues. So what happens is if you get too much load on the back, you have improper technique, then you can have muscle strains, spasms, things like that. So if muscles are working harder, structures are working harder, there's more chance of getting injured. That's probably the simplest way to explain that. Does that answer the question? Maybe, maybe not. And yes, to a certain extent, there's going to be more. Okay, that answers the question. And again, if it didn't answer the question, don't be shy. You can always reach out directly by sending a direct message. So if you have normal tilt, so I'm not saying you're not supposed to have any anterior tilt. You technically have a bit of anterior pelvic tilt naturally. That's going to happen. But I'm just saying when there's too much, and too much usually, you can see it, right? You can see someone do a squat. You can watch yourself from the side. And if you have certain issues, then we assume, okay, it's likely a pelvic issue. And the best way of finding out is to adjust the tilt and do the activity, whether it's a squat, lunge, whatever it is. You adjust the mechanics and test it out. See how it feels. If it doesn't feel good, adjust it some more. If it feels better, then maybe stay in that kind of pattern. So lots of different little ways to do things. A lot of people are very, very strict on squats. I tend to let certain things go, like the width of the legs and which way the toes are pointing. If it's at the gym or something like that, with therapeutic squats, different story. So it just depends on what your goal is or what the activity is. Any other questions? That was a good question. We'll give it another minute, and again, I'll mention my coordination of clothing. Every day our idea is to just do like a funny theme. So I got little rocket ships and like stars and spaceships, and then I got my socks. I got the same thing. So yeah, thank you. Good luck, socks. All right, similar question to yesterday. Okay, so the question is similar to the question yesterday, and I remember when someone has issues with squatting in the hip, do you tend to just decrease the volume and continue working on the same exercise? Yeah, that could be one option. Like it depends. If the pain isn't like a 8, 9, 10 out of 10, then yeah, maybe adjust it right there, take a little bit of volume off, and then you know, okay, this could just be a volume issue. What I'll typically do with individuals is just fully assess them and then start easy and kind of go heavier into it with activity and volume. So yeah, let me just reread that again. Yeah, like I mean, as a physio, I don't like taking out certain exercises of people's programs. I understand people have a wide variety of activities and exercise programs, and even though it might not be an exercise that I perform, I'm still interested on the patient's or individual's behalf. So I try not to get rid of certain activity or exercises unless they're doing quite a bit of harm, right? So if that's the exercise that caused a significant issue, then I would avoid doing it. But for the most part, I try to change the volume a little bit. So, and this is what I can comment on, and you'll hear it often, whether it's on Instagram stories or on these live videos. Second one being today, I work with a lot of Olympic weightlifters and some powerlifters. So those sports I understand very well, and some martial artists from the past. But with Olympic lifters, I will tend to just decrease the volume. So if they have certain inflammatory responses, they still need to train. They still need to do their program. So then I will actually, I'll adjust those things, and usually it's fine. So typically it could be the body just being inflamed, training a bit too hard. I'll take those exercises down in terms of volume, and it's usually never an issue. Okay, that helps a lot. And you can apply that to anything with the shoulder, hip. Change the volume a bit. Maybe don't take the exercise out unless it's causing excruciating pain. If it's a 10 out of 10, you shouldn't be doing extra. You probably should be at the hospital. So yeah, we have like a minute and a half. Sorry, this is taking a bit of time, but I think it's a good discussion. So any other questions? We have about a minute left. And again, you can always direct message us. The clinic's closed to the public. We're doing telehealth. So we're doing physio 101 over like Zoom or avenues like that. So I'm still here all day. So don't be shy of asking questions, emailing, or sending direct messages. So don't be afraid of sending those things. I'm glad to answer those things. Me as a physio, I like being a physio, and it drives me crazy not being able to treat patients. So if you have questions, I'd love to answer them. And if I can't answer them, I got lots of colleagues that I can bounce ideas off. I mean, I have a playground in this clinic that I can trial exercises out and figure out things for you guys, take videos and stuff like that. So yeah, feel free to drop us a line. And yeah, thanks for tuning in, guys. Thanks a lot. I appreciate it. We'll be back tomorrow, actually. Let's see what the topic is. I have a whole schedule here. Tomorrow will be posture, tension headaches, prolonged sitting. I know a lot of people are staying at home from work, so we'll be going through that. And there's 12 seconds, so see you guys later. Thanks a lot. Good. All that.